Hello, thank you for the introduction. So I will speak about resistance to long-acting antivirals. Long-acting agents may offer the potential for less frequent dosing. And I will speak about some examples of agents with less frequent dosing, such as injectable cabotegravir and rilpivirine, a combination of integrase inhibitor plus NNRTI. I will speak also about islatravir that has a potential of subdermal implant and weekly oral dosing. Islatravir is a new class of nucleoside reverse transcriptase translocation inhibitor. And then I will speak about lenacapavir, that is a first-in-class selective HIV-1 capsid protein inhibitor with potential subcutaneous and weekly oral dosing. These long agents may offer a lot of advantages for patients. However, there are some concern around drug resistance if the patient does not come back on time. In the ATLAS and FLAIR studies, long-acting injectable cabotegravir plus rilpivirine has been evaluated versus daily oral 3-drug regimen. In the ATLAS studies, patients were previously suppressed on the stable ART regimen. And in the FLAIR study, patients were naive. Patients were first treated by an oral regimen during several weeks and then switched to long-acting cabotegravir plus rilpivirine monthly versus their continued baseline ART regimen. In the pooled analysis at week 48, long-acting cabotegravir plus rilpivirine was non-inferior to continued baseline ART with a very high rate of virological success. However, there were some virological failures with the emergence of resistance mutations in these studies. 3 in the ATLAS study and 3 in the FLAIR study. As you can see, at time of virological failure, the 6 patients developed NNRTI resistance mutations, and 4 of them had developed resistance mutation to integrase inhibitor, 1 with a 155 and 2 with a 148, that is an important mutation for dolutegravir. So there was some questions about the presence of the L74I mutation at baseline in 5 out of 6 patients. This mutation is a polymorphic integrase mutation that is highly prevalent in the subtype A1 that we can find in Russia. So there were some questions about the presence of these mutations and the capacity of this mutation to enhance the emergence of other resistance mutation to integrase inhibitors. At failure in these patients, per plasma cabotegravir and rilpivirine concentrations were below population means, but still within the range for most persons maintaining virological suppression. So there were some questions about the factors associated with the virological failure and the emergence of resistance mutation. So there was a post-hoc analysis on the effect of the L74I mutation on virological suppression at week 48. And as you can see, there was no meaningful difference in efficacy observed based on the presence or absence of the L74I at baseline in the FLAIR study. So probably there were some other factors associated to the failures. So in the ATLAS and FLAIR studies, monthly long-acting cabotegravir plus rilpivirine showed was non-inferior versus continued oral ART regimen. However, there were 6 confirmed virological failures with long-acting cabotegravir plus rilpivirine, and the 6 patients had an NNRTI resistance mutation, and 4 of them had also integrase resistance mutation at failure. So we know that rilpivirine has a low genetic barrier to resistance, and so I think it's very important to be sure that there is no potential pre-existing NNRTI mutations before the introduction of long-acting cabotegravir plus rilpivirine. And as far as we know, L74I mutation does not seem to have an impact on virological response. So considering the long pharmacokinetic tails of long-acting cabotegravir and rilpivirine, planned coverage will be required with oral ART when injections are missed or stopped in order to avoid the risk of emergence resistance mutation in case of virological failure. So now islatravir. Islatravir is a new class of nucleoside reverse transcriptome translocation inhibitor. Early studies showed that a single 10 milligram oral dose of islatravir produced antiviral effects for 10 days, and that parenteral dosing as infrequently as once per year may be feasible. Indeed, active triphosphate of islatravir has an intracellular half-life of up to 128 hours. And in a phase 2b study, ART induction with islatravir plus doravirine plus 3TC, followed by simplification to islatravir plus doravirine, demonstrated comparable week 4 48 efficacy versus doravirine plus 3TC tenofovir in treatment-naive patients. In this study, no patient meet criteria for resistance testing. So we do not have resistance data in case of virological failure within this study. However, we have some data about in vitro resistance profile of islatravir. And you can see that islatravir and tenofovir have complementary resistance profiles. Indeed, islatravir is hyperactive against K65R. And we can see also that TAMs confer a very low level of resistance to islatravir. However, 184V resistance is additive with TAMs. And here you can see that the 184V is increasing the fold change to islatravir. In addition, in some studies conducted in macaques, we can see that among macaques treated by islatravir, there is some selection of 184V, especially for macaques treated with a low dose of islatravir, and for those who had a high viral load. So in conclusion, for islatravir, it is more potent against some NRTI resistant strains than some other NRTIs are against wild-type virus. Islatravir seems to have a high genetic barrier against HIV resistance, with no or very low impact of K64R and TAMs. However, 184V seems to be an important mutation for islatravir. So islatravir is currently in development for potential subdermal implants and weekly oral dosing. So now lenacapavir. Lenacapavir is a first-in-class selective HIV-1 capsid protein inhibitor with oral and subcutaneous long-acting formulations in development. It has been demonstrated a picomolar potency in vitro, and its activity has been confirmed by high potency in a phase 1 clinical study with long-acting antiretroviral profile with potential dosing every 6 months. There are some data about in vitro resistance to lecanemab, and these data have identified capsid variants with reduced susceptibility to lenacapavir. So we conducted a study to evaluate the frequency of this capsid substitution associated with in vitro resistance to lenacapavir in antiretroviral naive and also in experienced patients in a large panel of different HIV subtypes. And as you can see here, we did not see this in vitro resistance mutation either in naive patients or in neither in ART experienced patients, patients without PI's previous use, or patients with an history of PI failure with PI resistance mutations. So lenacapavir is currently in development for oral and subcutaneous long-acting formulations. There are some already described mutations in the capsid that has been associated with a reduced susceptibility to lenacapavir. However, in some previous study, we showed that there is a lack of pre-existing resistance mutations in naive and experienced patients to lenacapavir. So in conclusion, there is a growing possibility of long-acting ART that is becoming available for people living with HIV. Of course, those ARV with long-acting formulations should have a high genetic barrier to resistance. So there is a need to find a good companion considering the very long half-life of these drugs. And also there is a need to find a good patients candidate. There is some debates about adherent patients versus non-adherent patients who should receive these kind of formulations because these have some implications, for example, to determine the coverage strategies in case of treatment interruption to avoid the risk of emergence mutations with these formulations. Thank you for your attention.